The next speaker is Siddhartha Yadav from the Mayo Clinic, and he will speak on population-based estimates of contralateral breast cancer risk among carriers of germline pathologic variants in ATM, BRCA1, BRCA2, CHEK2, and PALB2.
On behalf of the Carriers Consortium, it is an honor and a privilege to present our study on population-based estimates of contralateral breast cancer risk among carriers of germline pathogenic variants in ATM, BRCA1, 2, CHEK2, and PALB2. Our understanding of contralateral breast cancer risk in germline mutation carriers is currently limited to BRCA1 and 2. For ATM, CHEK2, and PALB2, contralateral breast cancer risk is not well defined. Even for BRCA1 and 2, contralateral breast cancer risk has primarily been investigated among women qualifying for genetic testing. Furthermore, the effects of several other important factors, such as age, menopausal status, race, ethnicity, and use of adjuvant endocrine therapy, has not been comprehensively evaluated in the context of germline mutation carriers. Therefore, there is a need for precise estimates of contralateral breast cancer risk in pathogenic variant carriers from population-based studies to inform surveillance, risk-reducing strategies, and guide a personalized approach to risk management. The CARRIERS study is a population-based case-control study which enrolled more than 30,000 women with breast cancer as cases and a similar number of matched unaffected women as controls. The association between pathogenic variant in each gene and breast cancer risk has been previously published in New England Journal of Medicine in 2021. In that portion of the study, ATM, BRCA1, BRCA2, CHEK2, and PALB2 were all associated with moderate to high risk of breast cancer. Utilizing the same cohort, we looked at 15,104 women with unilateral invasive breast cancer from 10 epidemiological studies in the United States. All women were prospectively followed for contralateral breast cancer event. They were excluded if they underwent bilateral mastectomy for initial breast cancer. They also required at least 1 year of follow-up. We also excluded women who had DCIS at initial breast cancer diagnosis. And then we looked at the results of 5 genes of interest for this study. We performed a time-to-event analysis comparing contralateral breast cancer risk between carriers in each gene versus non-carriers. The multivariate proportional hazard regression analysis accounted for competing risk of death. And then censoring was performed at last follow-up or contralateral prophylactic mastectomy, whichever came first. The multivariate model was also adjusted for contributing study, race, ethnicity, age at diagnosis, menopausal status, histology, ER status of the first breast cancer, and the use of endocrine therapy. The median age at diagnosis of the patients in this study population was 62 years. 63% of women in this study were black, whereas, 63% were white, whereas 15% were black. 73% were postmenopausal at the time of initial breast cancer diagnosis. 75% of the tumors were ER positive, and 79% were of ductal histology. 46% of women received adjuvant endocrine therapy. The median follow-up duration of the entire cohort was 11 years. Approximately 4.5% of women in this study were germline mutation carriers in one of the 5 genes of interest. There were a total of 801 contralateral breast cancer events noted, 711 in non-carriers and 19 carriers of germline mutations. Here are the primary results from the multivariate analysis. On the left, the overall study population results are presented, and on the right 2 figures, we present the results by ER status of the initial tumor. The black dots and the horizontal lines on this figure denote the hazard ratios and 95% confidence interval for contralateral breast cancer risk in each gene compared to non-carriers. For BRCA1 and BRCA2, there was at least 3-fold increased risk of contralateral breast cancer risk compared to non-carriers, and this was true in the overall population and in the ER-positive and ER-negative subset. For ATM carriers, we did not observe a significantly elevated risk of contralateral breast cancer. Whereas for CHEK2, we noted a 2-fold increased risk in contralateral breast cancer risk. Interestingly, for PALB2, we did not observe a significantly elevated risk of contralateral breast cancer, in the overall cohort or in the ER-positive subset. However, for PALB2 carriers with ER-negative breast cancer were noted to have approximately threefold increased risk of contralateral breast cancer. Often in my practice, I find that the absolute percentages of contralateral breast cancer is more helpful to guide clinical decision-making than hazard ratios. So for BRCA1, the cumulative incidence of contralateral breast cancer from first breast cancer diagnosis was 23% in 10 years, compared to 4.3% in non-carriers in 10 years. For BRCA2, the 10-year cumulative incidence was 17%. Now, these numbers are consistent with prior studies, especially in a particularly in a prior study that demonstrated that 10-year contralateral breast cancer risk in BRCA1 was 23%, and in BRCA2 was 21%, similar to our numbers. For ATM, the 10-year cumulative incidence of contralateral breast cancer was 4%. For CHEK2, it was 8%. For PALB2, the overall study population, the 10-year cumulative incidence was 7.9%. However, for PALB2 carriers with ER-negative first breast cancer, the 10-year cumulative incidence of contralateral breast cancer was 19.7%. Among 54 PALB2 carriers with ER-positive first breast cancer, there was only one contralateral breast cancer event noted, despite a median follow-up of approximately 10 years. Further analysis by menopausal status was performed. And in this figure, the orange bars denote 95% confidence interval and hazard ratios for premenopausal women, and the blue bars denote the same for postmenopausal women. In general, the hazard ratios, the point estimates of hazard ratios appear to be higher for premenopausal women compared to postmenopausal women. Again, looking at 10-year cumulative incidence of contralateral breast cancer by gene, for BRCA1, the 10-year contralateral breast cancer risk was 33% in premenopausal women compared to 11% in postmenopausal women. For BRCA2, 27% versus 9.5%. For ATM, the contralateral breast cancer risk was fairly similar between pre- and postmenopausal women, 2.9% versus 4.6%. For CHEK2, this was 13% in premenopausal women compared to 4.3% in postmenopausal women. We also looked at contralateral breast cancer risk in women over the age of 65 at first breast cancer diagnosis. In this subset of 6,010 women, 2.6% were noted to be carriers of germline pathogenic variants in one of the 5 genes of interest. Despite a median follow-up of 10 years, only 3 contralateral breast cancer events were noted, suggesting that the rates of contralateral breast cancer in this subset is low. Finally, we also looked at contralateral breast cancer risk by race ethnicity, and the orange bars over here denote hazard ratios and 95% confidence interval for non-Hispanic white, and the blue bars denote hazard ratios and 95% confidence interval for black women. As you can see from this plot over here, that the point estimates of hazard ratios for BRCA1 and BRCA2 carriers, whether they are non-Hispanic white or black African American, are fairly similar. So in conclusion, this is one of the largest studies of contralateral breast cancer risk from population-based prospective studies. What we demonstrate that BRCA1, BRCA2, and CHEK2 carriers have an increased risk of contralateral breast cancer. However, we did not find an association with an increased risk of contralateral breast cancer for ATM carriers. And among PALB2 carriers, only pathogenic variant carriers with ER-negative breast cancer were at an increased risk. The findings for ATM and PALB2 are quite interesting, and it, in fact, raises several questions, including the role of effect of adjuvant endocrine therapy in this subset of women. Black women with BRCA1 and BRCA2 have similarly elevated risk of contralateral breast cancer as non-Hispanic white women, and this suggests that the risk management strategies should be fairly similar between these races and ethnicities in germline mutation carriers. Finally, we also demonstrate that age and menopausal status at initial breast cancer diagnosis significantly influence the contralateral breast cancer risk in germline mutation carriers, and that these factors should be incorporated in our clinical decision-making, whether that's regarding surveillance or contralateral prophylactic mastectomy. Few limitations of this study to highlight that the number of events in some of the subsets were small. And then we utilized self-reported race ethnicity, and we were only able to perform the race ethnicity analysis for non-Hispanic white and black women. And finally, there were some concerns regarding the comprehensiveness of treatment data, in particularly regarding chemotherapy use and radiation. I would like to thank my mentor, Dr. Fergus Couch, for giving me this opportunity. I would like to thank the Couch Lab, where a lot of this work was done, our co-authors, and the contributing studies to the CARIES Consortium and this analysis. Thank you very much.
Okay, so there are several questions online asking, given that endocrine therapy reduces contralateral disease, what do we know about the endocrine treatment used in these different cohorts?
Yeah, so I think that's a great question, and we have looked into the role of, so not everybody in this study received endocrine therapy, even if they had ER positive. However, the challenge for us is that the numbers start becoming quite small as you break it down by mutation carrier and whether they used endocrine therapy or not. We have looked into this, and I haven't presented the numbers just because they're very small, and I don't think they're ready for public use. But for the most part, for CHEK2, we do see an effect of endocrine therapy. But for other genes, at least for BRCA2, we did not see that effect. Now, again, I think the caveat is that these numbers are small, and we have to take it with a grain of salt.
And we have a couple of in-person questions, starting with number 6.
Thank you very much. I really enjoyed that talk. I especially liked that you gave the 10-year absolutes as opposed to the hazard ratios, because I completely agree that as far as patients go, that sort of number resonates with them much more strongly than the hazard ratios. My question is, you showed the 10-year cumulative risk, but so many of these young patients in particular survive well beyond 10 years. Do you have a sense of what the cumulative risk would be at 20 years, for example?
Yes, and those numbers will be presented in a manuscript that will be published shortly in the next few weeks. So we will provide those numbers. The reason I provided 10-year is just so that we can compare across, and our median follow-up was 10 years, so that's the reason why I provided 10 years. But those numbers will be available in the next few weeks.
Microphone number 5.
Yeah, thank you very much for this very important study. I'm curious if you have a sense of how payers will look at this. As you know, we've had some challenges in getting some of our patients tested, even though, patients are interested in this, and it certainly can impact their treatment going forward. So my question to you is, can you speculate on how your data will impact our ability to test and manage patients, particularly your over 65 patients?
No, that's a great question, and these are always when we think of insurance coverage, it's always a challenging thing to predict. I think what's probably going to happen is after publication of our study, I think this is going to be taken up by a lot of guidelines. So NCCN, ASCO, and other societies are probably going to look at this data and decide, does it warrant a change in certain interventions, whether that's a screening, mastectomy, other things. I don't personally think that this should influence the testing realm, because the testing is primarily, at this point, the discussion and the debate has more so been whether we test everybody with breast cancer during their initial diagnosis or not. And here we are talking more about, after a contralateral breast cancer event. And, everybody agrees that if you have more than one breast cancer, then everybody should be undergoing testing at this point.
And don't forget to identify yourself at the microphone, microphone 4.
Andrew Tutt, Institute of Cancer Research in King's College London. Thank you for a lovely study. Could I ask about the co-occurrence of recurrence of the first breast cancer with the contralateral breast cancer? Because I think how we manage this is slightly different in the setting where someone develops contralateral breast cancer without any recurrence, particularly distant recurrence, as opposed to co-occurrence of a recurrence event.
So if I understand the question correctly, you're asking if there were contralateral breast cancer events together with distant recurrences.
Any form of recurrence, but particularly distant.
Got you. So we did not look at distant recurrences in this study. Our goal was just to look at contralateral breast cancer events only. For the most part, I think that's a valid question, that if you have distant recurrence, does your screening modalities change, and does that lead to, discovery of contralateral breast cancer events could change. For this study, we just focused on contralateral breast cancer, and we did not really look at the distant recurrence. That is our plan for the next study looking through this cohort is to, in fact, look at survival, distant recurrence, and account for contralateral breast cancer as well. We are planning that study for future.
Thank you.
And we'll take one online question as a last question and then move on.
So there were several questions about why do you feel the risk of contralateral breast cancer varies by menopause status at the diagnosis of first primary?
That's a great question. I think I think in general, even if we look at women who are not mutation carriers, we do see that the risks are different for contralateral breast cancer by menopausal status. I think the same is true in germline mutation carriers as well. Whether there is something additional, if there is an additional role of menopausal status and the hormonal milieu in propagating the contralateral breast cancer risk in germline mutation carriers, so that remains to be seen and investigated in future studies.
And along that lines, how many of the BRCA patients had prior risk-reducing self-oophorectomy, and how do you think that affected your results?
Great question. And so I think it's important to clarify that this cohort of patients that we have collected over here, majority of them were not aware of their germline mutation status. And so because they were not aware, it's unlikely that that a lot of women would have undergone prophylactic oophorectomy. These cohorts were collected as, in fact, these are like national cohorts that were collected several decades ago before testing was widely prevalent. So it's unlikely that that would have influenced any of these results.
Thank you.
Thank you.